It's my great pleasure to be here at the ESDR meeting in Salzburg and to have the opportunity to present to you today the results of an interesting study for the first time, which has come from Sydney, Australia. The disease that we're looking at is called Pemphigus. It's a rare life-threatening skin disease, and if you look here at these images, you can see examples here of patients with the condition. Until the advent of steroids, this condition was almost universally fatal, and for the last 80 years or so, all we've had are very big, strong blunderbuss treatments which suppress the immune system in these patients. Although it does keep them alive, these patients get a lot of side effects from these treatments, such as diabetes, high blood pressure, infections, and because it's a rare disease, it's been perhaps less attractive to pharma industry for looking for new treatments for the disease. However, finally, patients are getting some attention from the pharmaceutical industry, and in order to conduct clinical trials in this rare disease, we need to have ways to score that disease accurately. There are two ways to score the disease. One is called the Pemphigus Disease Area Index, or PDAI, which was developed in 2008 by an international group of experts. And the other is called the ABSIS, Autoimmune Blistering Disease Severity Index score, developed in Germany around the same time. In terms of validating whether these two scores are accurate, studies have been done in a variety of centers which have looked at whether two doctors seeing a patient in different clinics at different times can score the patient accurately compared with each other. And both of these scores performed well enough to be used in trials, although the PDAI was better in terms of the same different doctors assessing the patient at different times. Both scored quite well when it was the same doctor going back to see the patient again. In addition, groups have looked at cutoffs that determine whether patients are mild, moderate, or severe. So that's been done. But importantly, groups of experts who look at outcome measures for skin diseases have pointed out that all these outcome measures also need to be assessed in terms of something called responsiveness, which means that does the score change when the patient changes? You see that the patient has improved, and you have to be sure that the score isn't just changing due to some statistical chance, that it actually means something. The other thing that you need to be able to determine with a score is called the minimum clinically important difference, which means how much does that score need to change in order to signify something that means something in terms of whether you prescribe less treatment or more intense treatment for the patients. So in order to address this part of the equation that was missing, we made a plan to do a 2-year, both prospective and retrospective study in the patients attending our blistering disease clinics under routine care conditions. In these clinics, we have fellows and registrars who are seeing the patients, and those registrars scored each patient with a 1-page A4 sheet for the PDAI and the ABSIS score. I would go and see the patient as the PI with each of these trainees and would double check that they had done the scores properly, because some have got different levels of knowledge about how to use the scores. And I would also score each patient using a 0 to 10 physician global assessment or visual analog scale. I would use something called the PSADS, which stands for Physician Subjective Assessment of Disease Severity, which is basically saying whether you think the patient's mild, moderate, severe, or extremely severe. And I was asked to say whether I thought the patient was stable or had improved or had got worse. And if the patient had got better or worse, then I had to say on a Likert scale of 0 to -7 or 0 to +7, whether they had got a little bit worse, a lot worse, a little bit better, or a lot better. And this was all on a very convenient 1-page sheet, which was organized for me with the help of my research student, Sarah Hanna, and supervised by 2 fellows over those 2 years, Dr. Min-Hee Kim and Dr. Kathy Zhao. At the end of all this procedure, we had the help of statistician Nicole de la Mata at University of New South Wales Kirby Institute to help us to analyze the data. So in order to do this, the statistician said that you had to come up with a value that you thought you wanted to achieve in this study in advance of analyzing the data. And so to do that, we determined that we wanted to have at least a moderate Pearson's correlation coefficient of over 0.4, And so that was our predetermined hope that we would get that. In addition, I'll just flash to down here to the results. When the responsiveness was assessed using these statistical tools, using the Likert scale, the Pearson's correlation came up as 0.74, and that had a statistically significant effect for the PDAI activity. Using the PGA, it was also above 0.4, 0.46 with a significant p-value, but unfortunately using the PGA, the abscess score was not significant. We also did disease severity cutoffs, but my main purpose with this study was to look at what was missing. As you can see on this table, we got some different results for each of the two tools, but we got results that showed a minimum change of a 3 or a 5 for the PDAI using either of these two methods. But for the abscess, one of the two methods gave a score change of 8.5, whilst the other method gave a huge change required of 17. So we've decided to go with the one where the change is only 8.5 for the abscess, and the corresponding one for the PDAI was plus or minus 3, as these gave bigger area under the curve with the statistical analysis. The limitations of our study are that because it's a rare disease, we have a limited cohort of patients. In addition, most of our patients are in partial remission on a variety of treatments. They're not virgin patients with severe disease. So in order to improve the results that we've got, we're collaborating with colleagues internationally now who have a larger number of patients with severe disease, so that we can double check this data with patients from different countries and different severities of Pemphigus. So I look forward to updating you at one of our future meetings. Thank you very much for your attention.